Hi, I'm Dr. Ken Allen, and I am President and Executive Director of ISELP. Welcome to our podcast, where we're going to explore the mysteries of equine locomotor pathology, imaging, and sports medicine. What we're going to do today, we are joined by Dr. Kurt Selberg, and he is here with us. Kurt is a eminent radiologist and also has clinical experience from the times he spent with us at Virginia Equine Imaging. We're looking forward to having Kurt with us. Welcome.
Thank you. Glad to be here.
So Kurt, what we're wanting to do today is to, I wanted to do one. I've always liked some of these podcasts where they get to talk about the science and do a little bit of a deep dive into some of this. And I thought we'd take some studies that you were involved with and get a little bit into the nuances of them. And so if you're game, we'll get started.
Yeah, absolutely.
Okay. So you participated in a 2024 EVJ study, and that was on, the kind of topic on it was suspensory ligament and presale imaging, and you defined grades for suspensory ligament branches in yearlings and 2-year-olds, and you noted that, you could some changes, what was considered grade 1 in that paper, can be considered normal. Are these reference grades, are they kind of shaping the pre-sale evaluation, and can you connect them to long-term performance outlook?
Yeah, so the study was performed in a couple of different stages. That's by Dr. Frances Peet. She's one of our sports medicine residents, and now is down in New Zealand doing her stuff. She's got a super smart. She did a PhD as well, and so when looking at these particular ultrasound images, as you go look at the paper, there's 0, which is normal, and then grade 1, which has mild changes in the architecture. And so we went through and essentially figured out the grading system, and then did a repeated measures. Can we grade it the same way every time? And then went through and graded all these things for suspensory ligament changes. And the 0 and grade 1, the grade 1 actually, if there's minor changes, which could be indicating that there's remodeling and adaptive remodeling or adaptive stress change to the suspensory ligament, that means they're potentially ready to run. In fact, they had a higher percentage of earnings and starts, those grade 1 lesions, even comparatively to 0. And then once we get past those grade 1 to grade 2 lesions, they start to reduce their performance. Okay. And so they had less money earnings as the severity going forward, and then in the grade 3, they actually had reduced number of starts. Their probability to start was reduced. So for sure, those are going to shape, I think, outcomes and how the horses perform. It's actually started out as a study looking at the sesamoid bones and looking at the vascular channels and what people call sesamoiditis. The reality is it's probably not truly sesamoiditis. It's just changes with the bone ligament interface and potentially increasing some of the vasculature inside of it. Not always are they inflamed on advanced imaging. So we use the term sesamoiditis, but not always is it sesamoiditis. But we were looking at those to see if we could correlate what the sesamoid bones with the large vascular channels and what their racing history was, earnings, things like that. And does that necessarily go along with the suspensory ligament? And the answer is one of the first papers that came out was by McClellan, talked about that we had sesamoid changes, but they also had subclinical changes in their suspensory branches. So those two things might have gone together. And so it went through, and this kind of redefines of what's happening. So those kind of lower grades horses do really well because it's part of an adaptive change. And then we start to increase, then we're going to reduce our number of starts. And so for sure it's going to change for yearling and 2-year-old sales and race horses. Sometimes it doesn't necessarily apply to our sport horses as much. They're kind of two separate beasts, I think. And so extrapolating this information into the sport horse may not completely translate. There's plenty of horses that are well campaigned and they have a little bit bigger suspensory ligaments. They're heteroechoic on ultrasound, and the horses are doing just fine. It's just we find them there sometimes just on kind of screening that tend to do on some of these elite horses. But for sure this has changed what to look for, how we interpret those things going forward, and kind of somewhat dispelling some myths that existed with the radiographic stuff.
But it's more, again, this study was all about young horses, and the pre-sales evaluation doesn't necessarily, like you say, transfer over into the older adult sport horse. But one question I had on this was, and so a two-part. One is that I've always wondered, you'll see this low-grade bony remodeling, but the fibers look good. And I tend to look at that and say, you know, that was probably in the past, that was, like you say, modeling, remodeling change when the horse was younger, but it's doing fine, it's not lame. Yes, we can find those little bit changes, but they're not a big deal. And I tend not to get too excited about that. Is that your take on those?
That's absolutely my take on the older horse that's been ridden for a bit. Those are adaptive changes and what we sometimes expect. And one of the things we didn't necessarily do on this study, but I do fairly frequently to see what's happening in there. They may have these changes, but I also use color Doppler interrogation to see the vascularity in there, because they're more likely to be lame from the lesion when they have increased vascularity in those ligaments. So I do that a fair amount as well to try to go in. And whenever you look at a ligament, you can do cross-sectional area. And a lot of people use cross-sectional area as a cutoff to say normal versus abnormal, and I think you'll overdiagnose and underdiagnose when you use that cross-sectional area. That we're not always that repeatable in our cross-sectional area drawing.
Yeah, I've seen that a lot.
Sometimes I'm dead on. Sometimes it looks like my 3-year-old did it. But it's just depends on how much coffee I had that day. As you go through, there's a lot of variation in cross-sectional area, and I think that if we're just using cross-sectional area to say, and especially in this study, they found that if you increase the cross-sectional area in Dr. Pete's study, they had delayed the first race by an average of about 50 days. And I think that is interesting because not always, I think, is it like a hard cutoff. So I wouldn't use that as a hard cutoff. I think it's a tool that we have in our chest. And that same thing for proximal suspensory ligament, especially in the hind end, is, we used to measure this thing coming from a plantar approach, and we're missing a third of the ultrasound, and then 2006 came around, we started to come to that medial area, and now I do more of a non-weight bearing plantar approach to get the entirety of there. But the suspensory ligament.
But now with that, you're commonly using a linear probe, but set to a virtual convex.
I usually do, just to get a better idea of the side lobes that come in. I just get more information at the same time. But the cross-sectional area, you'll notice in a lot of these horses vary from anywhere from 1.5 to 2.75 and be completely normal in terms of a horse. No abnormal fiber pattern. The fat muscle bundle to tendon fiber definition is really quite crisp. There's no bone margin change. But if you had measured it and that's what you use to cover as a cutoff, thinking that 1.5 is a normal one and it's a 2.7, they'd go in and cut the horse, and that's not the horse's problem. So it could be in the tarsus, and we know that those two things go hand in hand, but the same thing up front is there's a bit of variability, although albeit less variability than in the hind limb. But if you're using measurements as a hard cutoff, that can be, I think that can be a pitfall of things. It's a tool, like I said.
And I know we're going to talk more about the proximal suspensory in the hind limb a little bit later, but I know you're a fan of looking at the margins of the splint bone, drawing a line across that
Yep.
from one to the other, and then saying, oh, well, the proximal suspensory has bulged out of that area, and therefore, at the minimum, it's swollen.
Yeah, it's bigger for sure. And I'd use that same thing. The other things that I look at as we go through that area are: is it compressing the metatarsal artery that runs immediately adjacent to it? Is there other thickened tissue around it? What is the fat muscle bundle definition doing? Is there adjacent bone resorption? And then if there is adjacent bone resorption, I'm really scrutinizing that area, and especially dorsal medial and dorsal central aspect are the two most common sources of or areas of fiber disruption. And not always, when we look at a suspensory ligament, are the lesions hypoechoic? Are they clinically relevant? And I think that's another thing, at least that we have looked at with advanced imaging, is see these things following up, where we get to see that the lesions aren't necessarily what you traditionally think is a lesion. They can be heterogeneous to hyperechogenic, and using on and off like contrast imaging, using anisotropy as our friend, we can see how the fibers are. Are they all aligned? And so if we go off angle, everything's going to be uniformly black. If they're hyperechoic on angle and off angle, that's probably more likely immature scar tissue. And now we know that. And then if they're hypoechoic on angle and hypoechoic off angle, those are malaligned fibers. And it's not a hole that we can put something into. It's already healed. It's just malaligned.
Right.
And I think all of those things kind of going together into the suspensory ligament are important for me. And those are what I do every day, is those things. I rarely do a cross-sectional area. And one of the things, at least for ISELP, was always to compare one side to another. I find the hind suspensory ligament is not that helpful all the time when comparing to the other side, because the other side might have had an injury and it's just going to stay the same size no matter what. And so if you're going to use that as a comparison, so you always have to, for me, I tend to use blocking pattern, physical exam, and then my gamut of that checklist that I just mentioned for looking at the suspensory ligament to say whether it's abnormal. And the other side could be or couldn't be abnormal, but I find that sometimes muddies the water, if you will. For sure, if there's variation, and I'm wondering it's just a variation in the shape or the muscle bundle definition, I'll look at the other side, although there is asymmetry in the horse, but I'll look at the other side for some symmetry stuff.
Right.
But not necessarily like to convince myself that one side's abnormal.
Well, and I think that's some of the takeaway, just to review for a second. So we were talking about hind limb proximal suspensories, and remember, they come in pairs. They want to come in pairs. The front limb, no. Usually a unilateral injury, front limb will heal much better and quicker, and the hind limb will tend to present more as a chronic, commonly confused with hock pain, and sometimes commonly coupled with hock pain.
Yeah.
But you have to try to differentiate it or treat both of them when you're doing it. But I think the point Kurt was making is that you don't have to do cross-sectional areas to compare. You do have to look, if you're going to do it standing, look at that medial oblique angle and get a good look at, is that suspensory bulging out from between those two splint bones and the artery. And then 2, make sure you pick the leg up and do not only the medial oblique, but do that plantar view as well. And if you have a machine that will let you do with your linear probe a virtual convex. And don't be afraid to drop the frequency a bit. If you're struggling to see it, you don't have to be operating at that 10, 11, 12 megahertz. You can drop that frequency down to an 8 or a 9 and penetrate through there and get the look. So don't be afraid to do that.
Yeah, I totally agree. You don't want to struggle, and dropping that frequency is one of the first things that I do. And sometimes it actually makes the lesions more conspicuous with the lower frequency. It just seems like blacks are black and white are white, so it kind of illustrates that area a little bit more. Not always is the case, but that tends to be what I think about. The one thing about that plantar approach, you have to realize what are things that are angle dependent, and bone is angle dependent too, right? So it requires you to be perpendicular to it to get a nice returning echo, and that medial approach doesn't get that all the time. So that plantar approach, and that plantar approach is paramount for looking at that bone margin, and we know that the bone margin and the bone ligament interface are a really common area of injury, and that's very important. So if I see irregular concave resorption at the suspensory origin, I'm really scrutinize that suspensory ligament quite a bit more right adjacent to it. And so there's just little things to go along the way, but that's why I do that non-weight bearing plantar approach. And the way I tend to do it is, some people just cock the leg. I tend to bring the leg back and out behind itself like it's in a farrier sling.
Right.
And I get really good control of the leg, and I get nice pressure on the transducer. Comparatively to just cocking the leg, I feel like I get a better image. When you pull it forward, you tighten everything. So if you're coming from like a dorsal approach because the horse is a wing nut, and you pull it forward, you're going back and tightening those flexor tendons, which you're defeating the purpose of looking at that, because you want to reduce the tension on those. So if you just bring the leg back just a little bit so you can have a nice easy structure to manipulate around, it helps out quite a bit too.
I think that's a great point. Well, let's move on to our next topic, and this was a paper that was published in Animals, and it was one about MRI follow-up and healing timelines, and I think has some good points to it. And so you talked a little bit about why don't I let you jump into what you were talking about, and I can ask my question as we go.
Yeah, so as we look at the suspensory, and was centered on the foresuspensory ligament, and what was kind of cool about this particular paper, and this was done by Liz van Wegel at SMDC in the Netherlands, along with some other very smart people. Liz is a boarded equine radiologist and also an ISELP certified member as well, but did this together. And when we looked at looking at the MRI and the kind of healing pattern, how long it took to get back to that place, we went over that, but we also tried to normalize the suspensory ligament for abnormalities, meaning, as we do the cross-sectional area, can we have an internal structure we can measure it against to say this is the normalized suspensory ligament. And we did the cross-sectional area of the bone compared to the suspensory ligament, the tendons compared to the suspensory ligament, and we couldn't get those to come and hold true as a ratio, which you would think then that would kind of negate horse size, but we couldn't do it. And that goes back to then cross-sectional area measuring. Is it that useful?
Right.
And this would suggest that it's not that useful in that respect. But the cool thing about this paper is that it goes over the healing time as it relates to increased signal on fat suppressed images. STIR is what we tend to use in this particular paper, which is suppressing the signal from fat, so you can see some fluid infiltrate into the osseous, into the intertrabecular space in the osseous structure. And the hyperintense signal can be a wide variety of things as we look at the differential diagnosis. And so we call as a catch-all bone marrow lesion. And the bone marrow lesion, which I think is probably a pretty good kind of just radiographic diagnosis, if you will, or ultrasound diagnosis, and then we have to have a differential diagnosis of what it actually is. And that can vary from edema, inflammation, increased vascularity, degenerative cellular infiltrate, microtubercular fracture, osteonecrosis, hematoid deposition, fibrous tissue. I mean, a whole host of things. And when we think about it, we want to think about then transient nature differential diagnosis, and then things that will stick around for quite some time. And the edema, inflammation, and contusions tend to be transient, and then those will resolve their signal. But oftentimes what it seemed like is it's not full resolution in the signal for the horses to be back to sound. They just clinically get better. And so I think it goes back to not only treating you're looking at the imaging, but you got to treat the horse. And I think that's probably one of the most important things when we think about this is, relying solely on the imaging to dictate what is happening for the horse moving forward. For sure, there are certain things that I'm going to look at, especially in the suspensory ligament. If it's static, meaning on ultrasound, if it's static and looks the same, is the same size, and the bone margin hasn't changed, that's positive for me. And I think that is a good thing to know going forward, because the suspensory ligament's never going to really return back to a normal size shape, and the bone margin never really tends to completely smooth out. It's always a little bit irregular, and the ligament is enlarged or has some heteroechoic or heterogeneous fibers at wherever it previously torn. And one of the most important time points in looking at those suspensory ligaments is right before the horse goes back into full work, because that is its new baseline. And I think that's really important to go through, because if we're expecting complete resolution, that's usually it doesn't happen. And so we want to know what to look for putting the horse back to work. And for sure, the going through these studies has helped us kind of understand when we would potentially rescan, when we would potentially help ourselves go back into work. And that is interesting, because in this case, right, the complete resolution of the hyperintense signal on the fat suppressed images wasn't correlated with horses being completely sound. So some horses had this residual fluid signal and they were sound on it. So clinically, the horses are much better, but there's still some fluid signal sitting around. So sometimes we can't let the imaging modality completely dictate what we're going to do. We have to use our clinical intuition, our hands, and how the horse is doing on that day. Can we increase the workload?
Because it's not only just the bone. I mean, in this paper, the hyperintensity was resolving in about 94 days, but you've still got the soft tissue lesion. And is it resolving in that time frame? Has it responded to treatment? What have you done? Have you shockwaved it? Have you, injected PRP or A2M around underneath the fascial plane? It's just like you say, the soft tissue and the bone may be healing at different time frames. They may be tracking each other, but you've got to determine that as a clinician. Know that, it's great that now that probably 3 months that bone is going to start calming down, but has that soft tissue calmed down?
Yeah, and usually the soft tissue is our rate limiter. You think about that. And a classic example of that is, P3 fractures that are non-articular and go right through the collateral ligament fossa. They tend to, if you just have a straight palmar process fracture, the bone heals pretty quickly. We've had horses that are crazy and they're back to work in 5 weeks with a P3 palmar process fracture. Not recommended, but they do it. But if they have that component that is soft tissue and it's the collateral ligament, they can take significantly longer to get back to work. Yeah. So that's one of the beauties of understanding all of the things that are in there. It's not just one injury oftentimes in the horse. It's oftentimes seems like it's a conglomeration of injuries that tend to put the horse over the edge and are performance related issues.
So I think one of the things I wanted to talk a little bit about today was particularly, there are so many choices in imaging nowadays. And, it used to be, when I was growing up and riding around with my dad and his truck, your choice was the hoof testers or the x-ray machine. That was it. And, now we have to decide between CT, radiography, MRI, and then not only do you have to decide between those to help you get the initial diagnosis, but then now you have to decide additionally what you're going to follow the horse with.
Yep.
Because, following the horse with a few radiographs is pretty inexpensive for the client. Following the horse with CT is certainly cheaper than, particularly a standing CT. Doing it with an MR, whether standing or under general anesthesia. But so MR is going to be more expensive, but give you some advantages in bone edema and soft tissue that you don't get with the others. CT is going to be quicker, give you the three-dimensional imaging piece, but still cost a lot more than a radiograph. So when you're kind of putting this together for veterinarians, and I know you probably get this question daily, because veterinarians not only want to know what they should be, where they should be moving this case toward, and then there's nothing more frustrating probably for you than a case that you would have seen them, they need to go to CT and do a contrast study, and instead they went a completely different direction, and now you've got, a suboptimal scanning technique that you have to interpret. So how do you work that?
Yeah, I think that's a valid point, and even a great question. And whenever you say it's a great question, there's not always a great answer. But the thing about it is, you look forward. For me, it's always the front line of diagnostics are the ones we start with, and I think that's important to start with those, because if we say everything's got to go to CT, we're making those other imaging modalities seem obsolete, and they're not. I think they're very important modalities. And occasionally, when you go through the first kind of studies, the radiographs and the ultrasound, you may not see the image or the abnormality because it's masked, there's summation, there's a tough acoustic window on ultrasound to not see it. And then you send it on to some advanced imaging modality. And one of the things you have to think about when we're looking at advanced imaging modality is what the strengths and weaknesses are each one, right? And so, just as you said, the CT versus MRI, and their standing CT is becoming much more widespread and available to do in a fan beam CT, which is important because fan beam gives you good contrast resolution versus your MRI. And so you got to think about what is the disease process is going to be most likely in this case. Do you suspect a soft tissue injury? If you do, then either one of those modalities will give you good information. CT, oftentimes people think about CT just for bone. If you're using fan beam, it has really good soft tissue detail and higher and potentially higher resolution, meaning more kind of dots in the rows and columns that are far superior to MRI, and we get to see the nice tears in the deep digital flexor tendon, collateral ligament injuries. There's artifacts in those you have to know about, otherwise you can overinterpret. And then MRI, if we're thinking about that MRI gives us great soft tissue resolution or soft tissue detail, but also gives us some different kind of chemical information on our bone marrow lesions that you had talked to as well. One of the things, if you think about CT versus MRI, is that if we have a negative scan on a CT and we've done a regional lymph perfusion or arterial phase contrast imaging and we don't see any lesions that are occultly hypervascular because they're injured, then we also know what it isn't, and then we can make a supposition of what it potentially is based on what we know it isn't. And I think that's equally as important information. So the only problem with that is if it's a bone marrow lesion, we don't know exactly where it's sitting to help treat those horses. So sometimes, let's say we have a distal dorsal P2 fluid signal that can be a contusion, right? Sometimes those will have, over time, can degenerate and some of the cartilage can kind of go in that area. But we wouldn't necessarily see that on a CT to know we wanted to treat the distal interphalangeal joint. On MR, we know where we'd put our treatment and target our treatment. So knowing that location can change how we're going to treat, which I think is important. So how do you if you have a CT and you get rapid information, what do we do next? Well, we can send them on to MR for sure, but I think there's also another option where we can send them to a focused nuclear scintigraphic exam and now we get all the physiologic and anatomic images. And there's other things I can do for contrast enhancement to look at the bone as well. Where I co-register the pre and post contrast, and then I take away the calcium or the bone and then look at just the contrast area. That doesn't necessarily, all of the things that I just said don't necessarily answer your question of which one do I use. And that is a diagnostic conundrum right now, I think, is figuring out all the places we need to do one versus another. And I think for sure, there are areas that can be challenging. One of them can be the collateral ligament of the distal interphalangeal joint in the CT. There's known kind of beam hardening artifacts that kind of go through that area that can look like a hypoattenuating fiber disruption. So what we try to do with those is help ourselves out by using contrast. Right. And so if we're not seeing a ton of stuff on the initial scans, we oftentimes will do either arterial or regional imperfusion positive contrast in there to look for areas of contrast enhancement.
But that's easy to do with CT, and that's one of the huge advantages. It's quick,
yeah.
And if it's standing there next to the machine, then you just do it.
Yeah.
And right then and there.
Absolutely. And then the other thing, and I know this is going to be a bit counterintuitive, but when we look at cartilage, a lot of focus has been laid on cartilage and looking at MRI and what it detects. And there's been a couple of studies that have shown CT arthrograms versus MRI native and then arthrograms on MRI that CT had more conspicuous lesions with the positive contrast extending into the cartilage erosions. And so you could say that if it has a surface erosion, which is oftentimes what we see, that CT is going to be superior to MRI for cartilage evaluation.
With contrast.
With contrast.
Right.
Yeah.
And I think that's huge because I think that, two points that you make there, one of them is that, we as a profession have, in the past been taught to, well, CT is great, but it's bone only. Yep. And that's not true anymore. In the modern fan beam CT picture, it's getting very good soft tissue resolution, and in some cases better than what you can suss out with MRI.
Yeah, they're thinner slices. You get through those areas really well that have good definition between the adjacent structures, which is very important to look at. And then we have that added thing of looking at contrast. And the soft tissue, I think people are, and this is only relating to fan beam. Cone beam imaging is a different beast. It has really high spatial resolution, very poor contrast resolution,
right?
Because of the amount of scatter. Does it have a place? Yeah, if you can use it in concert with an MRI, and then you're worried about something happening in the bone, although it's usually on the MRI, the CT will help illustrate it a little bit better.
And I think Penn uses commonly, they use PET scanning, mm-hmm. and in concert with their
Standing
cone beam.
Yep.
Right, and so there you take the shortcomings of the cone beam and you make it up with another imaging technology.
Yeah, for sure. And there's two different tracers that you can use, and that's FDG and sodium fluoride. And the sodium fluoride is a bone tracer, while the FDG is more of the soft tissue, looking at metabolic activity in the tendons and ligaments. And I think that's important. So if you're missing the soft tissue component to it as well, you might do two different radio tracers on your PET scans to try to figure out those differences. So I think it's reasonable to combine certain imaging modalities. But again, like I said, trying to choose one can be a bit challenging. So again, I go back to look at all of the differential diagnosis that I think are going to happen, and which one do I think can see what are my primary differential diagnosis is, and then I'll move it to that area. And so that oftentimes I'm actually leaning more towards standing CT a lot of times, but I'm also, like, if I think there's a bone marrow lesion or I think that there's infection potentially, I might lean more towards MRI, trying to figure out what's happening with the MR.
Yeah, and I think I had a case the other day that was an interesting one, and it was one where we were concerned about hocks, and we had some hock lesions, and then we were concerned about the proximal hind limb suspensory too, and we had ultrasounded it. We thought it was a little swollen, but the question was, well, is there a significant bone? We had the hock question. So, and I said, we can MRI this. And again, with the standing MRIs, I mean, they've absolutely been game changers over the years and letting us do these things, but they're not quick.
No.
You stand there for hours acquiring these sequences. And so, the client, this particular client, had been through this thing with me on another horse MRI, and she said, oh, now we gotta schedule the MRI, we gotta go up and do it, we gotta do this, and we gotta wait for the report. And I said, well, actually, fan beam CT, which we've just recently acquired, gives you really good bone details, so we'll know everything you want to know about the hock. And I said, we're going to get good soft tissue detail, and we're going to be able to look for, is there a bony lesion, bony lysis, bony sclerosis going on at that attachment of the proximal suspensory? And she said, well, how long is that going to take to do? And I said, well, I'll tell you what, the longest time it takes to do a CT like that is for the horse to wake up from the sedation. We're going to be done reading the image long before that, and then we send the image to you, and you come back to us pretty quick. So, we can get that client an answer quickly.
Yeah. And I think the other cool thing about CT is that oftentimes our scan fields of view are a little bit bigger. And one of the first images or first horses we put into your CT, the horse blocked beautifully to PDs. And the lesions that were actually the primary source of the lameness were bone demineralization, subchondral bone injuries in the fetlock that blocked to a PD. And that happens quite a bit. And oftentimes in MR land, you do a PD and you just order a foot instead of going all the way through the fetlock. And I see that weekly where PDs will block out a fetlock lesion. And so the beauty of the CT is you get bigger area faster. And it gets you information for sure.
And less money for the client, and yet you get the diagnosis. So I think a lot of at least my perception of what CT could do and couldn't do has changed, particularly since, and I agree, you have to be careful about separating this conversation particularly if you're going to talk about the soft tissue, and separate the cone beam from the fan beam.
Yep.
But if you're talking about the fan beam, you're going to get some good soft tissue differentiation. I mean, I was amazed at what all I could see in the soft tissue, and even to the point where I started going, well, that can't be real. And
Yeah.
then I sat there and looked at it and I go, actually, that is real.
Yeah, it's amazing. You start to get to look at these CTs and the lesions and how well they're delineated on CT. I think it's been a game changer for getting horses in and out. And also, the beauty of what I'd said is that, okay, we didn't see him on our first images, and we sent it on to advanced imaging. Now go back out and use that advanced imaging to our advantage and use some special radiographic views or ultrasound techniques to see if we can see it and follow it up over time to have the cheaper follow-up session.
Kurt, I know you've had the opportunity to be at a couple World Equestrian Games and Tokyo Olympics doing the imaging and commonly nowadays, for those of you who aren't familiar with it, is there will be either radiologist or ISELP certified imaging specialist at these major World Equestrian Games or Olympic Games, and that's been a trend now for many years. Can you tell us a little bit about what that experience was like doing that at an Olympics with these world-class athletes? And maybe you can share a story, but no names.
You can do this. Yeah, it's been an absolutely phenomenal experience because I get to go out and watch these horses compete, and then I see they'll come into me in for a checkup for something. And what's cool about these venues is that all of those services are free. They can just bring the horses into the main hospital or go to stall side and scan and repeatedly scan the horses over time to make sure nothing's changed. And really cool example of how this actually changed the outcome for a horse or enabled to compete was horse came in, had a little focal swelling in the metacarpus region, ultrasounded it. It was sensitive to palpation, but it was subcutaneous, and the tendon itself was relatively normal. But for all the world, you could say that might have been a bowed tendon, and the horse gets spun, goes to the hold, and they're going to palpate that thing, and the horse is going to be reactive and not be able to go. And at this particular time, they've spent 4 years trying to get this thing to this place, and then to get spun out on the last type of scenario is really heartbreaking for an athlete. And so it's cool to be able to say, no, this is okay. This horse will be fine for the jump. And, in every way, shape, or form, we have to have the horse's best interest in mind. That's hands down what is. And so I think that's what has been cool about it is we get to scan these horses, and I get to scan them repeatedly over time. Like they come in, these horses are campaigned. They all have some little thing at some point that we just want to keep an eye on. But that happened on an event horse, and then there was a dressage horse too that had something similar, and you ultrasounded it, and I said I don't say that's got some fiber disruption, but at this point it looks like it'll hold roughly. It's not a terrible lesion. It actually looks like it's more chronic in terms of what we're looking at, and that chronicity can be challenging to figure out. And I go, the other thing it doesn't have is any blood flow in this area. It just looks big, but it does palpate a little bit sensitive. And so having that information to go back to go into the hold and say, hey, this was this, we know this, and had a couple of, those are just two examples of cases. There's been multiple cases where using that information, and oftentimes I'm housed in the same building as the FEI delegates. Right. And so we talk about stuff, but I don't necessarily talk about the imaging findings with any of them. We just talk about certain things, but they have the confidence in me to say, I'm here for the horse, not here for the rider per se, and I want to take care of this thing. And then the team vets will come in, and so it's a nice collaboration as we go through. And like, hey, Selberg said, the tendon's okay, it's just subcutaneous, it'll be okay.
Well, I think that's tremendous. That's how it should be. And, we're all there, and we've all made this journey for the welfare of the horse and make sure that it has its chance to compete if it's safe.
Yeah, exactly.
And you know, you're not going to make it perfectly safe for them, but the things that we can help them with and control, that's really useful. I want you to expand on something because we talked about it a little bit earlier in the thing, and you know, using color Doppler, and I think it's interesting, and for those in our audience who haven't used it a lot, because it has periods where it comes up and then it fades away, and they mean different things. So if you could expand on that.
Yeah, I think we're still figuring out some of what this means. And one of the things that I think about is if I have a horse that has a suspensory branch and it is heterogeneous, and let's say it's a 6-year-old reining cow horse. I expect that a little bit, but I also want to look and see if there's Doppler signal in there, and because that can be an indicator that this might be a problem coming up. And so I use that fairly frequently in terms of trying to identify clinically relevant lesions. Now, there are certain areas that color Doppler doesn't work that well in, and that is the proximal suspensory ligament, unless it's absolutely terrible looking. No, it's huge.
And is that because of the fascial kind of tension in that area?
Yeah, I think it's the reduced blood flow for sure. I think it doesn't get as much blood flow. Even if I do contrast enhanced CT, that area is, I don't think enhances as well with injuries as other places do. So, but yeah, the suspensory ligament, I think, can be a bit of a challenge with the origin, with the Doppler interrogation. But branches, the flexor tendons, they can all have increased Doppler interrogation, and I think they're more likely to be a clinically relevant lesion. Now, if we watch these things kind of, what we would say, ebb and flow, I don't think that they're actually, if they're persistent in color Doppler interrogation, I see this on branches, those ones will stay at a low-grade lameness. They have this persistent Doppler interrogation, increased Doppler interrogation signal, and when we look at those, have these persistent over months of time, those horses don't heal, and they seem like they're just stuck in this pattern where they won't heal. And that Doppler interrogation over time is really helpful to figure out, like, oh, this thing has a cessation and it's healing, and it's also painful, even though it's not like all that bad ultrasonographically in the architecture, it still has all this blood flow. So what we know, at least extrapolating from some of the human stuff, is that along with the vessels come nerves. And if we have this persistent blood flow, it may be a neuropathy that we're actually dealing with more so than anything else. And in those cases, then we need something to restart the healing, like reset the healing pattern in those. And that has helped change how I would address those horses in terms of treating. So it may be, oftentimes there's a whole host of things that people put in there, orthobiologics, and even using shockwave in addition to those, which I think is a great addition for sure. And a lot of horses respond really well and get them back to work pretty good. They usually, branches have a pretty good prognosis. Bone ligament areas, we kind of reduce that prognosis a little bit, but color Doppler interrogation can help us with those persistent ones. And I might switch over to debriding the ligament with a procedure that's called 10X, and where I go in and debride the lesion. It tends to seem like it resets the healing pattern, and the blood flow will progressively go down. There may be persistent blood flow and the horses are now sound, and I see that a bit, but oftentimes as the horses get better, the color Doppler interrogation, or the color Doppler signal, kind of goes down over time. And so I use that as a loose marker to say, yeah, this horse is getting better. So, but I think color Doppler interrogation has really changed me and how I address and think about things that are going to be clinically relevant.
No, that's interesting. And going back to World Equestrian Games, I was going to end with a story that, and you were at the 2010 Lexington Games, and you were young and early in your career back then, but I was the veterinary services coordinator at it, and like you say, we had free services, and so the people would take advantage of these, and they could run blood work and all kinds of things. And I had gone up to watch one of the dressage finals, and had then been called back down to the vet office, and there was a national chef to keep, and of one of the international teams, and he was just frantic that all of his horses had been drugged. And I'm going, well, what makes you think that? And he goes, there are blebs on every vein in our entire team. He said, someone has come in and drugged our entire team. I need an investigation. And so I start calling the FEI Veterinary Commission, and we've got the chief steward coming down, and everyone's about to roll into a full-scale evaluation. And what the heck's going on here? And I was just starting to think, and I was going, this is one of those teams that likes to do a lot of blood draws. And I said, you guys by chance didn't, first I walked over and I said, hey, has this team submitted any blood work? And they said, oh yeah, they just submitted some about an hour ago. And I said, well, who was the vet who submitted it? And they said, oh, it was Dr. So-and-so. And I said, why don't you call this guy and get him to come down here? And so all this, I just kind of kept that little tidbit to myself until I could figure it out. And so all this investigation is going on, and they're preparing to drug test all the horses. And this guy shows up, and I go, hey, you didn't by chance go to this team while everyone was up watching the dressage and draw blood on all of them, did you? And he goes, oh yeah, I did that about an hour ago. And I go, you know, next time you maybe want to mention that to the chef to keep and everything, because they thought their horses all just got drugged. So we wound down. That was a calming moment after the storm.
Yeah, that sounds like that the story was, the end result was communication is key.
Well, I want to thank you, Kurt, for joining us for this. This is a fascinating dive into some of the papers you've been involved with in the past, and helping us learn about it and really getting into the weeds. I really enjoyed it. I learned some stuff, and I hope the rest of the members of our audience did too.
I had a great time up here for sure. It's been a great experience.
All right. Well, thank you, our guest, Dr. Kurt Selberg. And we will look forward to hearing from you, our audience, and questions and topics you'd like us to get into. And hopefully you enjoyed us getting into the science a bit. And we'll look forward to you on our next ISELP podcast.